Okay, let's talk about this cool case of cocaine-associated chest pain. This is a 26-year-old male who stated he had no medical history. He presented to the emergency department with chest pain. It was central, pressure-like, and it did not radiate anywhere. It lasted a couple of hours. He admitted to cocaine use in the last few days, including 24 hours prior to presentation. In addition to pain, he had palpitations, shortness of breath, sweating, trouble sleeping, and loss of appetite. He also said he'd been drinking tequila to, quote, calm himself down, quote. On arrival, he's afebrile. He's tachycardic around 130. His blood pressure is elevated 150 over 92. He's a little tachypnic and satting well on room air. He appears anxious and diaphoretic, but otherwise well groomed and well nourished. He's dehydrated clinically. He's tachycardic. Otherwise, his cardiovascular respiratory exam are okay. And the rest of the exam is pretty much normal. This is his initial EKG, which you can see is fast and regular, so we'd call it sinus tachycardia. Intervals generally look okay in the PR, QTC, and QRS complexes. There's no obvious ischemic changes. He does have some non-specific stuff here. He's got tall T wave in V2 and maybe in V3. He's got an LVH pattern of the QRS complex. He's got flipped T waves in a couple leads. So definitely not normal, but when you're going 130 to 140, this can be sort of seen just based on that heart rate. No obvious STEMI. So this young fella has cocaine-associated chest pain, which of all of those patients, up to 6% of them end up having a myocardial infarction, so it's a big deal. There's multiple mechanisms, including vasoconstriction, enhanced platelet aggregation, and formation of blood clots, just generalized myocardial toxicity from the cocaine at use and increased oxygen demand. And long-term cocaine users definitely develop atherosclerosis and coronary artery disease. On the right here, we see sort of a diagram of what cocaine does. So it decreases sodium transport as a local anesthetic effect, right? Remember, cocaine works just like lidocaine. It has other effects too, which causes arrhythmias and QRS QT prolongation, can affect LV function, okay? And then perhaps more importantly, it increases sympathetic output in catecholamines, which cause vital sign instability, coronary vasospasm, increased platelet adherence, which all lead to ischemia and infarction. And people do die from cocaine use for this reason. Treatment generally starts with rest, oxygen, cardiac monitoring, IV access. The big thing is they have to admit they were using cocaine. Not all patients will do that. You want to give them aspirin if it's not contraindicated. In general, the treatment for cocaine chest pain is benzodiazepines, especially if they're agitated at all, but it sort of tampers down the sympathomimetic effects, lowers the vital signs, makes them feel better. Beta blockers are contraindicated. They can worsen cocaine-induced vasoconstriction. Nitroglycerin has been shown to help. Nitroglycerin with benzodiazepines is even better. And then if they're not getting better with just that, phentolamine is sort of a next line agent that has been shown to help with cocaine-induced vasoconstriction. On the right here is a table sort of suggesting those same treatment options. So aspirin's indicated, you should give aspirin. Beta blockers not appropriate. Benzos for sure, and you can use different benzos. It doesn't have to be lorazepam. Calcium channel blockers I have not used but are an option. Nitroglycerin for sure, and then phentolamine is down here as well if you need it. Disposition, well, low and moderate risk patients can safely go home if their EKG and troponin are normal, or if the EKG becomes normal during their time in the emergency department. You need to observe them for a while, of course. High risk patients are going to be admitted, and patients with abnormal workup are going to be hospitalized, and cardiology will need to see them, right? Those patients, if they have a troponin leak or STEMI, they need more care than just what you get in the emergency department. In the case of our patient, he admitted to cocaine use, so we call it cocaine-associated chest pain. He ultimately received aspirin, 3 doses of 1 milligram of IV lorazepam, and 3 liters of normal saline. Remember, not only is he sympathomimetic, toxidrome, but he also is clinically dehydrated. His troponin was okay. His creatinine was a little elevated. Otherwise, his labs look good. His repeat EKG had returned to normal sinus rhythm, and his vital signs normalized. And then, of course, we counseled him on discontinuing cocaine use. Here is his repeat AKG. You can see it has slowed down quite a bit, right? This heart rate is now normal and regular, so this is normal sinus rhythm. You can see these really big T waves in the precordial leads had subsided. The flip T waves in the inferior leads have subsided. So as he, as he normalized, his EKG got a lot better. So 3 key points about cocaine-induced chest pain. It carries a risk of acute myocardial infarction at about 6% of all ED presentations. That's pretty high. Initial treatment is basically benzodiazepines, but you can also give them standard chest pain therapy like aspirin and nitroglycerin. And do not give them beta blockers, as has been shown to worsen coronary artery vasospasm.